Welcome, everybody. We'll get started in a minute or two, leave some time for people to access the Zoom link. And I'm keeping track of the numbers of the participants joining us. So the numbers are still moving up quite a bit. So we'll get started in just about 1 minute. Great, folks. So we're just about to get started. We're just waiting for some other individuals to join. And here is my mark. It's 2 minutes past the hour, so we'll get started today. So I would like to welcome everybody to this public forum, an event that is organized annually by BioCanRx to discuss various themes and what's happening in research across the country here in Canada. My name is Stephanie Michaud, and I'm a co-chair and moderator today, and I'm also president of BioCanRx. So before we get underway, we want to acknowledge, and can I have the next slide, please? Oops, the next one too. Perfect. Leave it there, please. So before we begin, we want to acknowledge that BioCanRx is situated on the traditional unceded territory of the Algonquin and Anishinaabe people. We acknowledge and respect our traditional hosts and thank them for allowing us to operate on this land. It is also important to recognize that we are gathering virtually, and I encourage all of those joining us to learn more about the traditional land they are on by going to whos.land website. Next slide, please. So as I've mentioned a little bit earlier, this is a public forum. It is a webinar. It is taking place today for about an hour and a half, a little bit less now. And it is an event that we have started doing, as I've mentioned earlier, to discuss what is taking place in research in Canada, specifically in the area of cancer immunotherapy. And it is by design set up to be an accessible webinar. So to tell you a little bit about BioCanRx, we are a not-for-profit that invests in the development of immunotherapies for the clinic. So the development of immunotherapies so that then we can go forward and fund different types of clinical trials. And we're a network of scientists and clinicians and NGOs and companies from across the country and internationally, all working together in order to make that a reality. And the mission of BioCanRx is to accelerate to the clinic the most promising immunotherapies designed to save lives and enable a better quality of life. So the topic for this year is owning the podium. And so how did we come up? And can I have the next slide, please? And so why did we pick this theme? Of course, this was developed by our co-chairs, which I'll be introducing in a couple of minutes. But we were inspired by what had been accomplished at the Vancouver 2010 Olympics, where great successes were achieved by the Canadian teams. Of course, it was a home Olympic taking place in Vancouver. And so 5 years before that, the decision had been made that Canada was going to target to hit a target of obtaining as many medals as possible in these Winter Olympics, and they did. And what was extraordinary here is that it was an alignment of different groups, and it was an alignment and investment of these different groups, and a dedication to a very, very targeted mission. I hope that you'll see today, at least at the end of the public forum, how some of the activities that you're going to hear about today very much align with that kind of mission, that kind of attitude, that kind of alignment. This public forum here today could not happen without the support of our sponsors, and we are very grateful to Merck for sponsoring today's session. So we're about to kick off, and may I have the next slide, please, for a few housekeeping items. So today's presentations, as I've mentioned, are meant to be accessible to everyone, and we welcome your questions throughout the event. If there's something that is not clear or that you're having difficulty understanding, please do not hesitate to write your question in the chat, and we will do our best to get to this. So if you'd like to ask the question, please add it to the chat box. The forum, as you've seen from the little red dot in the upper left-hand corner, is being recorded and will be posted after this event on the BioCanRx YouTube channel, where you will have access to it and watch it at your leisure. We absolutely love and listen to any and all feedback. So a survey will appear when you exit this webinar. Please, if you have time, we would very much appreciate it if you would fill it out. And if you don't have time, no worries. It will also be emailed to you following the event. So a little bit more about our panel and to get into introductions. And can I have the next slide, please? Thank you. So today we're going to hear from a scientist and a surgical oncologist, both of whom are involved in clinical trials using novel immunotherapies that are made or were made here in Canada for the treatment of patients. And you will also hear the incredible story of a patient that has participated in a clinical trial that was funded by BioCanRx. So you probably noted a change in the appearance of certain individuals on this panel, and I regret to inform you that unfortunately, Vera Sammarkina was not able to join us today, but we greatly thank her for her role in helping us develop this session according to this theme of owning the podium for cancer immunotherapy in Canada. So we're very, very pleased, very fortunate to welcome Camille Leahy, who will be joining us as patient partner today and sharing with us her incredible story. So just to recap what this panel will cover today, we're going to further delve in onto the why Canada should want to own the podium in cancer immunotherapy. We'll kick us off by a presentation by John Bell for an introduction to immunotherapy, what it is and how it works. We'll hear from Camille on what is a clinical trial and how to access a clinical trial, specifically an immunotherapy clinical trial. And lastly, we'll hear a case study on what it takes to introduce an exciting new immunotherapy called tumor infiltrating lymphocytes, or simply TIL, and that's all caps, TIL, T-I-L, therapy to Canada. And that will be from Simon Turcotte. We hope that you too will see that Canada needs to be as bold and as ambitious as the scientists, the patients, and clinicians that you will hear from today. So now I would like to introduce you to our co-chair, Louise Binder, and she's co-chair of the Public Forum. Louise Binder is a lawyer and patient advocate who has been involved in developing health policy and systemic treatment access issues since the mid-1990s following her own diagnosis with HIV. This work was done through the Canadian Treatment Action Council, our acronym CTAC, which she co-founded in 1996. Louise began similar work in oncology 6 years ago and is presently a health policy consultant with the Save Your Skin Foundation. She has been recognized for her work, including receiving an honorary doctorate of laws from her alma mater, Queen's Law School, the Order of Ontario from the province of Ontario, and not one but two Queen Elizabeth II medals. So over to you, Louise.
I hope you can hear me and see me. I apologize for the slight delay. My computer decided to pop up 3 or 4 screens that had absolutely nothing to do with this presentation. So thank you very much, Stephanie, for the very kind introduction. Certainly we have BioCanRx to thank for hosting this event, and I echo Stephanie's thanks to Merck for sponsoring it. And of course, most of all, I thank all of you who have joined us today to talk about this very important issue. Today's theme, Owning the Podium, from my perspective, refers to the importance of stakeholders in the healthcare system determining the direction of research, development, and implementation of research strategies for cancer. We need those strategies that will truly inspire the incredible research, talent, and opportunities we have in Canada to make real strides in conquering cancer, strategies like the US Moonshot and the Beating Cancer Plan in Europe. So since the 2016 launch, the Moonshot has supported more than 70 programs and over 250 research projects in cancer, including in the area of immuno-oncology, representing an investment of $1.8 million. Europe's Beating Cancer Plan has the mission of removing discrepancies in cancer care and outcomes within their member states. It will invest €4 billion of funding and is focused on the entire disease pathway. It's structured around 4 key action areas, and they are 1, prevention, 2, early detection, 3, diagnosis and treatment, and 4, quality of life of cancer patients and survivors. The European Cancer Organization has set the following ambitious goal of increasing cancer survivorship to 70% by 2025. Regrettably, we in Canada are far behind in developing a strategy for the delivery of research and development of the badly needed precision medicine treatments, including immuno-oncology and accompanying diagnoses badly needed by people with cancer. Such a strategic focus would fit ideally with the federal government-funded Canadian Partnership on Cancer and its goal of facilitating action on cancer control in Canada. It also specifically aligns with one of the share's priorities that was recently part of the agreement between the federal government, the provinces, and the territories, which is working together to improve healthcare for Canadians. That priority is to create a modernized healthcare system. Modernization surely includes leading-edge cancer research. We cannot miss this pivotal opportunity at the very moment that immuno-oncology and precision medicine advances are being made in an incredibly rapid pace. We must set the bar high, and we must meet the high bar that we set for ourselves. We must own the podium so our voices can be heard by decision makers and our political leaders, telling them that people in Canada consider cancer to be an epidemic and calling it on them for leadership and strategic thinking, planning and implementation of cutting-edge strategies without delay. We have done this before, and we can do it again now. So I turn it over to you again, Stephanie.
Thank you so very much, Louise, for those incredibly insightful remarks. I could not agree more from the perspective of BioCanRx, and I'm sure many, many others on this call, that kind of leadership is needed. I'll now turn it over to introducing our first panelist, and it's my pleasure to introduce to you Dr. John Bell, who is the Scientific Director for BioCanRx. He is a world-renowned thought leader in the development of immunotherapies, in particular oncolytic viruses, research and development. In addition to his many academic contributions to the field, Dr. Bell established a GMP biomanufacturing program in Ottawa that has produced clinical grade oncolytic viruses for worldwide use in clinical trials worldwide. He is a senior scientist with the Ottawa Hospital, professor of medicine and biochemistry, microbiology, and immunology at the University of Ottawa, and an entrepreneur, having launched 2 companies to advance his inventions towards the clinic. Having recognized the need to further support the development of immunotherapies right here in Canada, he's also the architect in 2014 and is the scientific director of BioCanRx. And he is the one that launched Canada's Immunotherapy Network, a network of centers of excellence. Dr. Bell is both a fellow of the Royal Society of Canada and the Canadian Academy of Health Sciences. So I'd like to turn it on over to you, John. Thanks.
Thank you, Stephanie. I'm going to see if I can share my screen without messing it up. Okay. How's that, Steph? Is that looking good?
It's looking good, but I think you need to share the screen because we can see the doc at the very bottom of the screen.
The dock at the bottom.
Yeah, we can see your, your Apple doc.
Am I, oh, I see the thing at the bottom there.
Yeah. Mm-hmm.
How about now?
Oh, there you go. It's perfect.
All right. Excellent. So yeah, thanks, Steph, for the introduction. And I want to speak today a little bit about immunotherapy for cancer. I really believe this is going to be the way we move forward in the field to really provide people with great outcomes and hopefully, in many cases, permanent cures of their disease. Now, this first picture here I'm just showing you is one of our favorites of BioCanRx, and it just speaks to the concept that rather than try to use strategies that have been used in the past, like chemotherapy, radiation therapy, and surgery, we think it's possible to educate a patient's immune system to recognize their own cancer as a foreign entity and then eliminate it. So I'm just going to speak in a few slides about what I mean about that and why this is a great idea. So first of all, chemotherapy is, let's just make sure. Do you see the whole slide, Steph, or is it?
Yep, I see the whole slide. Yep.
Okay, perfect. Chemotherapy is the mainstay of treatment here in North America, around the world, for the treatment of cancer. And if I said to you, I know a woman who's going through chemotherapy for her breast cancer, for instance, an image like this picture here might come to your mind. And the reason that is because we know the chemotherapy can work. It does attack the cancer, but unfortunately, it also attacks the normal tissues of the patient. And so this woman, as she goes through her therapy, has lost her hair from the chemotherapy because the drug has also attacked her normal hair follicles as well as her cancer. She's probably got sores that show up in her mouth, or she's sloughing off the lining of her intestinal tract because there's this inability for the chemotherapy to completely discriminate between the cancer and the normal tissues. And this is a limitation which often prevents us from being able to get complete cures for people, because we have to stop treating them because, unfortunately, the chemotherapy is attacking their normal tissues. And so what we really all want to get are called cancer-targeted therapies which hit that cancer bullseye and don't hit anything else. They don't go and hit off-target places. So we want to get therapies that will actually attack only the cancer and leave the rest of the tissues of the patient unscathed. That's really the dream of my lab, and really thousands of labs around the world are trying to develop these kinds of therapies. And I'm going to speak of a particular kind of therapy, which is immunotherapy, which is being developed at a really rapid pace now, because it has shown signs that it will be exactly this, a targeted therapy that will attack the cancer and leave your normal tissues unscathed. So what is your immune system? So this is just a picture here to illustrate that it's actually a very, very sophisticated network of tissues and cells that patrol our body at all times. So we just got through the COVID pandemic, all of us here. And the reason we did is because our immune systems kicked in, either through natural infection or through a vaccination. And as a result, we developed immune cells that could go around your body, circulate, looking for sites of infection. And those immune cells are very sophisticated and very targeted. They only attack, for instance, an infected cell and not a normal cell. And in the end, they end up clearing the infection. Of course, this is why, and we're exposed to viruses at all times and bacteria. And this is when you get your measles vaccination, you don't get measles again because your immune system has been educated. It then patrols your body looking for a site of a measles infection, and it saves that memory for the rest of your life, pretty much. So sounds great. If you got something that's very targeted to a site of infection, can we make it so that it's targeted against cancer as well? And so that's really the dream that we've had for many decades. And now I think we're really starting to see that this can become a reality. So can we use our immune systems to attack cancers? I think that there's lots of ways this can be done, and I'm only going to speak about one today. And that is the use of what are called T cells or thymocytes. These are cells, immune cells that form in your thymus when you're very young. And so hence we call them T cells for thymocyte. And over the left-hand side here is just to put a circle around what this T cell is like. And the important feature about it is it has on its surface sensors which allow it to detect an infected site and then go in and attack it. And the T cell, once it recognizes an infected cell, it'll go in and actually kill it and destroy it, get rid of it. And that really blunts the infection and stops it from continuing to progress within your body. So really effective against all kinds of infections, parasites, bacteria, and viruses. And our goal really has been to try to re-educate those thymocytes or those T cells to also recognize that cancers are foreign as well. And one kind of therapy that has been really successful is so-called CAR T cell therapy. And on this picture here, you can see what I've written at the top there, chimeric antigen receptor. That's how come we came up with the acronym CAR, because what we do is we take T cells and we engineer them. So this is, so when a patient undergoes CAR T therapy, what we do is we collect blood from the patient. We isolate their T cells through a variety of very simple procedures. This T cell might be educated to infect influenza-infected cells, or it might be educated to infect measles-infected cells. So we take it, and then we reprogram that cell. We actually use a virus, as it turns out, to reprogram that T cell so that now it is going to express on its surface a new receptor. This is a so-called chimeric antigen receptor. Or CAR, and now that T cell is grown up to make an army of these T cells, all with the capacity to recognize something through this CAR. And the CAR, this chimeric antigen receptor, is designed specifically to recognize something on the surface of a cancer cell. And therefore, when we take that bag of T cells and put it back into the patient, these CAR T cells will attack and kill any cancer found within that patient. That's the theory behind this. And this is just one way to use T cells that's been really effective. And I want to give you an example of how well this can work. So Emily Whitehead is really an amazing story. So this is back in 2011. You can see that poor Emily had developed a leukemia, acute lymphoblastic leukemia. At the age of 5. She went through, and it was considered probably a curable disease, but unfortunately not all people who go through this therapy are cured by the standard therapy. And at 7 years old, she had failed all therapies, including a bone marrow transplant, and she was considered to be terminal. And her parents were told that there's really nothing more we can do for Emily. Our standard treatments are not going to work. So she was fortunate to be actually in Philadelphia and able to enter into a phase 1 clinical trial. This was a clinical trial which was testing the concept of using one of these chimeric antigen receptor T cells that I spoke about, the CAR T cells. In fact, she was the first pediatric patient to ever receive one of these genetically modified CAR T cells, and it was used to try to fight off her leukemia. And it's an amazing story. And in fact, these new cells that were infused into Emily worked. It's actually a great story, and she was very close to end of life at the time she went into this clinical trial, and yet she was rescued from really the brink of death. And now here's a picture of Emily in 2021. I just actually spoke to her earlier this year, and she's doing great. She's 19 now. She's very bright and doing great in school. So this is an example of how an immune cell therapy can be used to completely rescue someone who was really very, very sick with cancer. And it's all through the use of an engineered immune cell that this can happen. So it's an amazing story. Let me tell you about another person. This is Stephanie Dupont, Canadian woman. She was a bit older than Emily when she developed the same disease, acute lymphocytic leukemia. And unfortunately, she also went through the whole gamut of therapies, and nothing worked. And she had failed therapy, and was also considered to be terminal. That's when she fortunately met a colleague of mine, Natasha Kekri, who's at the Ottawa Hospital. Natasha's a brilliant hematologist. And Natasha knew about CAR T therapy. She knew about the Emily Whitehead story. So she said to Stephanie, look, we don't have this in Canada, but I do know the people in Philadelphia. We'll send you down there to see if we can actually do something to save you. So Stephanie went down to Philadelphia. It cost the government a lot of money. I think it was about $1 million to send her down there. But the result was that she was cured. And so that was great. And Stephanie is still doing well. She's, I believe she's in teachers college now. She's having living her best life, as they say. And all because she was able to get this CAR T therapy. But when we saw this result, and speaking with Natasha, we said, why is this in Philadelphia but not in Canada? We should be able to do better than that. We have lots of infrastructure. We have lots of great scientists and docs here. Let's see if we can't do it in Canada. And that's really what sort of was inspired by a meeting that we had together, the entire network that Stephanie described to you, about 400 people, patients, students, trainees, doctors, and scientists get together every year at our annual meeting, which is what's about to happen in Ottawa in this weekend. So this is back in Halifax in 2016. And we got together and said, why is it that we don't have this CAR T therapy in Canada? It makes no sense. We're all capable of doing this. And so a number of us got together over a nice beer, a schooner beer in Halifax. We wrote on a napkin, we can do this. We read a plan. And of course, went through a lot more detailed structure and applied for money. And we're able to actually put together a team that really spanned the country. People who were really interested in trying to solve this problem. We made the virus here in Ottawa, and my colleague Brad Nelson, who's in Victoria, produced the cells by using the virus to infect these cells that were collected at various sites around the country. It was then, I might have mentioned that originally the first construct that we had, that chimeric antigen receptor, was actually built by Dr. Rob Holt. Great people like Vari here and Maruna were involved on feet on the ground, making this all work, and Jen Quizzy in Ottawa. And we managed to put together a team that worked together very hard and made this all come together and work. And we started a trial with the support of BioCanRx in 2019. And this trial has been incredibly successful. We've treated over 100 patients now. I'm not sure exact what number we're at now, but a lot of these patients have done extremely well. Part of our strategy when we wanted to get this going in Canada is we knew that Canada had some unique issues. So Canada is a big country. Lots of people live in remote areas. Lots of people live in all the different provinces. And so we wanted to be able to create a situation where we could have access to CAR T therapy anywhere in the country. And so we really favor the concept of trying to make it so that each community would be able to make the CAR T cells themselves. And to do that, we developed what we call point of care manufacturing, which means that at each hospital, each cancer center in Canada, it will be possible to create a patient-specific CAR T product. And the way we thought about doing that was really to get a machine that would actually be like this bread maker here, where you just push a button and out comes the loaf of bread. And the idea was to try to get a machine that would work for making CAR T cells, just like this nice hot loaf of bread. And we were fortunate that a company in Germany had been working on this concept, and we were able to purchase some of these machines to put at various centers across the country. And it's a very straightforward robotic type machine that is well designed so that we can put a patient's blood bag into this, and it will actually do all the work, including using the virus to infect it. And it really only requires some monitoring by a trainee here, or an expert and a highly qualified person to run the machine. And in 10 days, we go from the patient's arm into a product which is going to infuse back into the patient. And what's great about this concept, that's something we're really proud of, that we've been pioneering in Canada, is that it's possible to use this at any site across the country in principle, and we should be able to make these CAR Ts accessible to everybody in the country. That's sort of our dream, our long-term goal that we're headed to. So this is all fine and good, but does this made in Canada CAR T product actually work? Well, we do have living proof that it works, and you're going to hear from Camille in a few minutes because she was on our trial and has had a really, really nice outcome. This is a picture here of Camille with her bright young daughter next to her, and really celebrated her life as well. But we'll speak a bit more about that in a second. I just want to tell you that these CAR T products have been very effective in certain types of blood cancers, which is great. You know, myeloma is another one which we're starting to see some really good traction in. But we hope they can be used and adopted to other kinds of common cancers like lung, colon, breast, and prostate. But so far, those results have not been as profound as we've seen with blood cancers. But we're hopeful that we can actually, through more research, more clinical studies, find ways to make the CAR T approach work for these other more common kinds of cancers. However, we're not just betting the whole farm on CAR Ts. We know there's other ways to use T cells, thymocytes in a different way. And you're going to hear about that from Dr. Turcotte, who's working on something called TIL therapy, which he'll explain in more detail. But it's just another way of using T cells to actually fight against cancer. And we're really hopeful that this will be another great way to move forward and help patients with treat their cancers. But back to Camille. She's going to speak next, and I'm very pleased to be able to introduce Camille. She's a very brave young woman who she'll tell you her story. But you know, to go on a clinical study is not necessarily a very easy decision. She really trusted a bunch of people who were just doing experiments and research, and she thought, I hope they know what they're doing, and it turns out that we did, because she's had a great outcome. So I'd like to just end here by saying thank you so much for joining us, Camille. She's been a great proponent of BioCanRx and really telling people her story to make sure that the people, in particular our government, understands that you know, it's very important to have fundamental research and clinical studies, because people like her have been able to benefit from it. So I will just end there, and I'll let Camille go.
Thank you, John. Hello, everyone. My name is Camille Leahy. I'm a 39-year-old single mother from Newmarket, Ontario. I worked in long-term care for 17 years until 1 week before my diagnosis. I wanted to take this opportunity to tell you how I advocated for myself and how I would like to continue to advocate in favor of better therapy, cancer therapy for Canadian patients. I want treatments like CAR T-cell to be made available to all Canadians and not just as a last line of treatment. On January 6th of 2020 at South Lake Regional Health Center, I was told that I had cancer. On January 7th, it was confirmed by a bone marrow biopsy that I had B-cell acute lymphoblastic leukemia and that I would need to go to Princess Margaret Cancer Center and begin treatment that they called an induction using the Dana-Farber protocol. After the month-long treatment as an inpatient with many struggles, including infections and 2 pulmonary embolisms, I was told that the treatment did not work. I would have to stay another month in the hospital to try a drug called blinatumomab. This drug did put me into remission, but I was told that my cancer was aggressive and that it was resistant to treatment, and my next option was to have a stem cell transplant. This was such a shock to me, since this was not the original treatment plan. My siblings were tested to see if they were a match, but to my surprise, none were. Fortunately, we found a 9 out of 10 match and proceeded with the process of transplant, which consisted of chemo and radiation. On July 9th of 2020, I received my transplant. I remained in the hospital for 1 month after recovering. At this point, we were well into the pandemic. I wasn't able to see my daughter or family and friends, and this was extremely difficult for me. But I knew that I had to continue fighting for her. She is what gave me the strength to go on. While recovering, I remembered a doctor named Dr. Jonas Mattsson. We were talking about my recovery, and I recall him telling me that if the transplant wasn't successful, that there were other options such as CAR T-cell therapy. I didn't think anything of it at the time, since I believed that transplant would be my cure. Unfortunately, at the end of March of 2021, I woke up one morning with some neck pain. I did not think it was anything serious, but as the days went by, the pain had spread and went into my legs. That is when I knew that something was wrong. I went to the emergency department, where a blood test confirmed that the cancer had come back. At this point, my transplant doctors told me that I was out of options. I was scared, but my doctors wanted me to try a treatment called hyper-CVAD. But when I heard the doctor begin listing off the names of the different kinds of chemotherapy, I broke down. They sounded all too familiar. I didn't think I could go through another month of treatment without being able to see my daughter and family and friends. I told him I couldn't do it, and he said that that was okay and we would find another way. During this time as an inpatient, the doctor suggested we try the same drug that had put me into remission before transplant. Unfortunately, I was not approved for this drug to be covered. At the time, my options were limited. The next drug we applied for was called inotuzumab. The only way I could be approved for this drug was to be an outpatient. While waiting to be discharged, I remembered the conversation I'd had with Dr. Matson about CAR T-cell therapy. I asked another one of my doctors at the time, Dr. Carolyn Chung, what about CAR T? She mentioned that there was actually a trial at the Ottawa hospital and that they would give me a referral. I was then approved for the inotuzumab, which thankfully put my ALL into remission. But part of the criteria for this trial was to have active disease. I was worried that this would stop me from getting into the trial. I really felt in my gut that I needed to get into this trial because my cancer was so aggressive and likely to come back. I am lucky that my cousin Jenny Ciccone works as an ER nurse at the Ottawa hospital and was so determined to help me get in. She watched an online talk on Made in Canada CAR T and decided to continue to advocate for me as she truly believed in this therapy. She emailed Dr. Natasha Kekry and told her how much she believed in this treatment and that I would be the perfect candidate. From there, I was contacted by Dr. Kekry and her team and began intake over a Zoom call. Dr. Kekry and nurse practitioner Linda Hamlin explained the process and risks involved. I was determined to make it to Ottawa as I knew time was running out. I made 3 attempts to make it out for this trial and would not give up without a fight. My first attempt was in June of 2021. Unfortunately, the evening prior to my in-person assessment before cell collection, I lost feeling in the lower right side of my face. The team was very concerned and did a lumbar puncture, which confirmed that the cancer had gone into my central nervous system, which made me unable to continue in the trial. From there, I was sent back home and began having weekly chemo through lumbar punctures. This was an extremely difficult time. I was so afraid that I would not be able to go back to Ottawa. Luckily, we were able to clear the signs of cancer and went ahead with our second attempt in July. The night before I was supposed to return to Ottawa, I had a fever that wouldn't break. I was so worried that I would not be able to return that I asked a family member to drive me straight to the Ottawa Hospital ER from Toronto. After a week of tests and antibiotics, tests showed that I had a fungal infection in my lungs and would again not be able to go ahead with cell collection and would be sent home to continue clearing up the infection. At this time, I knew in my heart that I couldn't give up, that this might be my last chance. I had faith in my team and was determined to get back to Ottawa. Then in September of 2021, I made the third and thankfully final attempt and went ahead with cell collection. During the next couple of weeks, I underwent chemo to prepare. This would not have been possible if I did not have family living in Ottawa, as I was not an inpatient at this time and needed support and a place to stay before admitted for CAR T. On September 15th of 2021, my modified cells were transfused back into my body. From there, I remained in hospital for 3 weeks, waiting for my counts to recover. After weeks in hospital, I finally went home and got to see my daughter. Though this time was so difficult, I was so very grateful to be home, and for 6 months I returned to Ottawa Hospital monthly. I'm so thankful for my family that lived close by. After 6 months, I returned every 3 months, and after 1 year, I returned for my last in-person appointment. I'm happy to say that September 15th of 2023 was 2 years post-CAR T-cell treatment, and there is once again no evidence of disease. I cannot begin to tell you how grateful I am to BioCan, the Ottawa Hospital, and to all the doctors, scientists, and nurses for making it possible. I hope my story can help others and help continue these life-saving Made in Canada treatments. My goal now is to continue advocating and doing everything I can to help others get a chance that I was given. So grateful to have spent the last 2 years making memories with my daughter and taking on new challenges. Thank you again for listening. I'm going to introduce to you Simon.
Camille, I want to say thank you for sharing your story. Every time that I hear your story, it's just incredible. So thank you very, very much for sharing your story with us as part of the public forum this year. I want to introduce our next speaker, who is Dr. Simon Turcotte. He is a surgeon scientist with expertise in solid cancer immunology and immunotherapy. After he carried out his general surgery training, he obtained after a master's in cancer immunology at the Université de Montréal. He completed postdoctoral training at the National Cancer Institute and at the Memorial Sloan Kettering Cancer Center, both in the US, focusing on metastatic gastrointestinal cancer immune recognition. It's during those years that he was introduced to TIL therapy, which is what we're going to be hearing about today. Since 2013, he is an assistant professor at the Université de Montréal, works as a hepatopancreatobiliary surgical oncologist, HPB surgical oncologist for short, and is a full scientist at the Centre Hospitalier de l'Université de Montréal, otherwise known as CHUM. His laboratory focuses on identifying new types of tumor antigens and therapeutically actionable immune checkpoints in colorectal cancer and liver metastases. He co-leads the launch of CHUM's adoptive T-cell cancer immunotherapy program and holds a clinician scientist research scholarship from the Fonds de Recherche Santé Québec. He is the Université de Montréal Roger Desgrosseilliers Research Chair in HBP Surgical Oncology. So Simon, welcome, and I would like to turn it on over to you now.
Thank you very much, Stephanie. And can you see me on the panel? And can you hear me well?
We can hear you, and we can see your presentation, but you have a beautiful image of a lake and a rock as your image, so we don't see you. There you go. Perfect. There you go. Perfect.
Great technology. Thank you, really, BioCanRx, for organizing this important webinar. Thank you, Vera, for sharing your journey, and what an amazing outcome also. I'm so proud to be a part of this team of scientists and doctors trying to develop immunotherapy here in Canada. Thank you, John, also for introducing the concepts that I'm gonna talk about today. For solid malignancies. So I'm going to talk about tumor infiltrating lymphocytes immunotherapy, TIL for short. Can move to the next slide. My research is funded by public funds, but also we are partnering with companies to do research in research and development. Next slide. So Vera and John have talked about blood cancers. 90% of Canadians and people in developed countries die nonetheless of solid cancers. These cancers arise from breast, from the colon, from the liver, from all sorts of solid organ. And next slide. T cells, the cells from the immune system that John described, can destroy any type of cancer cells. Can be cancer from the blood or a solid cancer. If you can start the video by clicking on the image, people will see, hopefully this works. If you just click on the image, you will see, yes, a T cell that recognize a cancer cell and leads to its destruction. It perforates the membrane of the cancer cell. It injects in the cancer cell some enzymes that degrade the cancer cell. Now, this is happening in the lab, and the dying cancer cell is becoming orange here to show the phenomena better. But in the body, this probably happens real time in a very similar fashion. Okay, next slide. So, as John mentioned, T cells patrol the body, and they can recognize abnormal cells. Cancer cells are abnormal. They express what we call antigens, which are short proteins that are abnormal. They're derived from the mutated genome of cancer cells. We call these targets neoantigens. There are other types of antigens derived from retroviruses that infects cancer cells, etc. And all these antigens can be recognized by T cells patrolling the body. And when those T cells enter the tumor, they recognize the cancer cells. They will try to destroy the cancer cell. They accumulate in the tumor. So the tumor results in being the best place in the body to find T cells that are trying to attack the cancer. Next slide. So more than 20 years ago, at the surgery branch of the NCI, where I was trained, Steven Rosenberg found, using animal models, that those T cells could be taken from the tumor, expanded, and reinfused back to mice as a treatment. Canadians have contributed to that early on. René Lafrenière is a surgeon from Quebec who then participated into this work and has done his surgical career, I believe, in Calgary after that, just to stem this as partly Canadian from the very beginning. Next slide. So this discovery led to clinical trials and an iterative process of trying to make TIL as a therapy as effective as possible. The general scheme is as follows. A patient with a metastatic solid cancer, a cancer with multiple tumor deposits in the body, comes in, and the surgeon takes a metastases and send this tumor to the lab. The cell lab chops that tumor in small pieces and put this diced tumor into a media that is supporting the proliferation, the expansion of tumor-infiltrating lymphocytes, which can grow to billions of cells. TILs have an amazing capacity to proliferate in the body, but also outside the body. So we're doing outside the body what is not happening at the tumor site. Once we have billions of those TILs, the patient is readmitted at the hospital, undergoes a preparatory chemotherapy to blunt its immune system to make room for the new anti-tumoral T cell infusion. Those TILs are then infused, and then we also give patients some immune stimulants. The most commonly used is called interleukin-2. This is a cytokine that promotes the proliferation, the survival of this live treatment that we've infused to patients. Next slide. So this treatment has been shown effective first and still is considered highly effective for skin cancer, melanoma. This is going to be a standard treatment in the very near future, and is already the standard treatment in some countries, as I'm gonna show in the next slide. This slide is a summary of all melanoma patients that have been treated with TIL at the NCI surgery branch, with a long follow-up of about 8 years. And you can see here that half of the patients that have been treated with TIL responded to the treatment, and 1 out of 4, 1 out of 5 patients, 22%, got a complete response. And it's only 1 or 2 patients who had a complete response who relapsed after TIL therapy. So if one has the chance to have a complete response to TIL therapy, the likelihood is that 10 years after and more, this person is going to be cured from a aggressive metastatic skin cancer. Next slide. This is an example of a patient that was cured with TIL therapy. This patient, as we see on the left side, prior to TIL, 25 days prior to TIL infusion, had multiple metastases in the liver. You can hopefully see a liver that looks like a cheese. All those black dots in the liver are cancer cells. These are metastases. And then you look in the central column, those scans, 34 days after TIL therapy, you can barely see those dots in the liver. And 5 years after, the patient has completely fought all cancer cells with TIL, and there's no more metastases in his liver. Next slide. So I just said that TIL is entering standard of care, and we want to prepare for that in Canada. And TIL is entering standard of care by two paths. One path, after the effort that were done at the NCI, one path was followed in Europe, in Holland and Denmark, along a scheme of medical innovation, like bone marrow transplant, like transplant of other solid organs. So the Holland team took the protocol from the NCI surgery branch, invested in their capacity to do point of care manufacturing, got public funding to run a large randomized controlled trial comparing TIL to another immunotherapy for patients with metastatic advanced melanoma. And they've just published their results passed in December that essentially recapitulated the results that were obtained at the surgery branch. Half of the patients had an objective response, and 20% had a complete response from TIL therapy. So this has led the Holland government health authorities to approve TIL for therapy for patients with refractory metastatic melanoma. And that team has now created a non-for-profit organization to file a full application at the European Medical Agency to have the full approval for TIL to be used as standard of care in melanoma. In parallel, you see the bottom part of this slide in blue. TIL has been developed by the commercial route, where a company called Iovance has invested into central manufacturing to produce TILs. So the company essentially have done a prospective trial, receiving tumors resected in various hospitals, producing the TIL product and freezing this cell product and shipping it back to the many hospitals that had participated in that trial for reinfusion into patients in local hospitals. They've just reported a lower yet still encouraging response rate for patients who were refractory to multiple lines of treatment, of 31% overall response rate, and still 6% of those melanoma patients had a objective complete response to this therapy. This company is now filing a biologics license application at the FDA, which is currently under evaluation. And we expect that this TIL product by Iovance is going to be approved by the FDA and potentially eventually available after evaluation by Health Canada and CADIT and other authorities in Canada. Next slide. But I think we have to decide, what do we want to do in Canada? Do we want to invest in public capacity and expertise in non-for-profit type of organization to do point-of-care manufacturing along what we've done for CAR T-cell, the the whole presentation and the whole approach that John has just talked about could definitely be used to introduce TIL therapy in Canada? Or do we want to continue to buy commercially produced TIL product and try to integrate this in our public health care system? So there are many ways we can move forward in an attempt to introduce TIL for standard therapy for metastatic melanoma. And I think it's really urgent that we get together and that we make the proper decision to make this available as wide as possible and sustainable in the public health system. Next slide. I want to end up this talk by saying that this is just a beginning. There are many T-cell therapies for solid cancer in the pipeline. You can see the exponential increase in the number of trials over the year. Next slide. The approach of TIL therapy is being tested in other types of cancer. Last year, there was 34 phase 1 and 2 trials running worldwide for TIL therapy. Next slide. John has talked about, click on the, yeah, you can continue to click. TIL has been shown to be effective. There is great efficacy signal in lung cancer. You can continue to advance the slide. In cervical cancer, in GI cancer malignancy, we've published, next slide, next click. Yeah, we've tested this approach in bile duct cancer, and we have a great story to share with you that we will share at the BioCanRx of a patient that is now alive 10 years after receiving TIL for a highly refractory bile duct cancer, Melinda Bikini, who's become a great advocate of TIL therapy and participation in and access to early phase trial. Next slide. TIL therapy seems to work best for solid cancer, but gene-engineered approaches can also work and are being developed, and early phase trials are open to test this approach. A similar approach that was described by John Bell in his earlier talk. Next slide. There are many companies investing in this development. Next slide. But the bottom line also, what we have to face is that there may be many TIL trials, many gene-engineered trials developed around the world, but it's urgent to make this, to open these trials here in Canada, because as of yet, we have not organized ourselves to make these trials available. There was only 9 solid cancer T-cell therapy trial open last year, and only 2, one at our center here at the CHUM and one in Prince Margaret Hospital for TIL therapy. Next slide. So the take-home message is that TIL immunotherapy can save lives of people with refractory skin cancer. It's entering standard of care in Europe and in the US by 2 different paths. Right now, we're watching this, but we need to make decisions, and we need to make it available in an effective manner for all Canadians with melanoma to have access to this effective treatment. We also have to organize ourselves as to make more early phase trial for the various types of innovative T-cell therapies that are being developed for solid cancer. Thank you.
So thank you to our panelists very much. When you finished, Simon, it really gave me hope. I hope it did as well for the audience, that the research that you and John Bell and many other really stellar researchers in Canada are doing will make a difference. So hope is a very important part, and the research that's at the heart of that hope is also very important. John, do you want to join us? There we are.
Yep.
So now we'll have a panel with our three speakers, and maybe we could start by I'll start by asking just a couple of questions. The title of this session is Owning the Podium. And what do you mean by that? And what's your vision of that and where it will take us? John, do you want to start?
Sure. I think you heard two great examples today of why it's important for us to own the podium, because we need to determine Canada's future for cancer care. We can't simply be riding along, waiting for someone else to develop these therapies and develop them in other countries where we don't have access to them. So I think it's really important for us to decide our future, to work together to bring things that are really innovative to Canadian cancer patients. And I think, as I said, if we sort of sit by and watch the world drift by, I think actually Simone said it very well in his thing, we can just sit and watch what's happening in the Netherlands, or we could actually do it here and make it happen so the Canadians benefit right now. I think one example I spoke of was Stephanie DuPont. It's a great story. I was glad to see Stephanie go to Philadelphia to get treated, but that cost about $1 million for the Canadian taxpayer. Was Camille, we only paid about $50,000 for her treatment. So, her hospital care on top of that, but the actual CAR T therapy itself was a fraction of the price. So we might as well just get on the podium and take it ourselves and control our own future. That's sort of how I feel about this.
Simone, would you like to add anything to John's comments about this?
Sure. I think first I want to say that instead of I called you Camille, I'm sorry I called you Vera because of the original plan we had for the conference. So I just realized that I misspoke, and my apologies. But yeah, I think this is something that has happened in the past, not only for cancer treatment but for transplant. Like Americans and perhaps Europeans had access to liver transplant earlier than Canadians, and this is innovation in cancer therapy, and we have to learn from the past. Yes, we have a different system than the American system, but I think it's not a reason to make treatment available later. It's a reason, and it gives the opportunity to give access to innovation earlier than elsewhere.
So how do people actually learn about clinical trials, and where can they go to get that information? John, do you want to start with that?
Sure. There are websites that we should go to. One is called clinicaltrials.gov, which is really lists lots of clinical trials from around the world, and it's a good place to start. And you just go there and put in your indication, the type of cancer you have, and maybe you might edit and say what kind of therapy you're looking for. You might put in, for instance, immunotherapy, or you can just put any kind of therapy, and it'll search and allow you to see what's available, at least in North America, and also to some extent in other parts of the world. And you can go there and say, does that make sense for me? And speak to your doctor and say, look, I think I need to have something. This is not working for me. I think Camille can speak to that very well. That's exactly the path she took. She said, I want something that's potentially work for me. And so you can look through there and try to find legitimate clinical studies that are really done in a well-crafted way with real science behind them and real validated research institutes. And I think that's a great place to start. But I think also just advocating for yourself, as Camille did. Maybe you want to speak about that a bit more, Camille, too, because I think that's really critical.
Yeah, Camille, yes. We'd love to have you comment on that. And in addition, what about the costs of clinical trials, and what's covered under clinical trials and what isn't?
So I think in my case, first of all, advocating for myself was the most important part, because, like John said, I was offered treatment that I had already done, and I didn't believe it would work. So I'm lucky that I had heard about the CAR T cell, but I do believe that it was me that pushed for it, and I'm the reason that I got into that trial along with the help of family, and I also would not have been able to participate in the trial if I didn't have family in Ottawa. So I think that's a big issue as well, is that the cost is obviously lower, like John said, but there's other things that need to be looked into. For example, places for us to stay or have this treatment closer to home, because other people aren't going to be like me and be so fortunate to have family that works at the Ottawa Hospital as well as lives close by, where they were able to support me.
And Simon?
Yeah, there are barriers to participation to early phase clinical trials. Some of them can be removed, in general, if we want to improve access to these type of treatments. For instance, transportation and lodging could be covered, certainly for patients participating in early phase trials, because we're coming to a point where more and more people recognize that participating in a trial is not just an experiment. It's a way of accessing care, of accessing new treatment. It's not, it's part of the care we're offering to our patients. And so we need to, I think, publicly and institutionally act on this and remove some barriers.
Thank you. And I'd like to go to a question from the chat. How can we increase research in Canada immunotherapy within the Canadian ecosystem? There are a number of promising Canadian-made immunotherapies being developed, but it seems very difficult to get funding for phase 2 trials to bring these promising therapies to more patients. Would you like to start with that one, Simon?
So the question is that it's hard to launch large trials for treatments that are novel, that are expensive. And the truth is that T-cell therapy is expensive, not only to make the cell product, but it's a hospital-based treatment. So there's also hospital resources that needs to be covered. We're partnering with companies to try to fund trials as best as we can. John Bell took the great leadership of organizing a large Canadian publicly funded network to promote the development of these therapies. Now I think we need to show what we've accomplished and get even more support from our government, from philanthropists as well, to do more made in Canada, investigator-initiated trials in cell therapy.
John, would you like to
Yeah,
add?
I mean, I think Simone nailed it on the head. We need to do, and I think the thing that has worked really well for us to date, and actually Simone and I also are on a grant from the Canadian Cancer Society to develop TIL therapy for a kind of cancer, which is a real team grant. I think it's just working together as a team makes our money go further. And I would encourage the government to try to put more money into these sorts of team efforts to really try to solve problems. I think, Simone works with companies, I work with companies, but I think there's also another path forward where we could do something like the Dutch have done, where they've formed a not-for-profit entity to really try to advance some of these things. And I think for some kinds of therapies like TIL therapy and CAR T therapy, that might be the best approach, because it's challenging for large pharma to grapple with the challenges of making personalized therapies for patients. And it's something that Simone and I do every day as part of our job. So I think maybe it's a better approach to think of some other strategies and get the government to get behind those, not-for-profit companies that are real entities that do good work, but just don't have a large investor base. Instead, we use it to service the healthcare system. And I think things like that could really make a difference for Canada.
So there's another question in the chat on this very point, asking about if we could create a Dutch model of a not-for-profit. Why can we not do that? And how, since, as you said, John, and you, Simon, there isn't the investor base, and we really do have these challenges. How can we galvanize the right stakeholders to make these therapies more available? And Camille, I'd be very interested in what you think from your perspective about this, about galvanizing stakeholders. What do you see from your experience, the role of stakeholders have?
I mean, I think awareness is the key. I think, like myself, I didn't know there was such an issue like this until I was sick myself. So I think awareness is where it needs to start. And I mean, I think BioCan's doing a great job by letting us patients speak and letting people hear our story, because I believe that would make an impact and helping get us money and donations and things that'll help keep these trials and researchers going.
So when you say educate, are you talking about the public?
The public and yeah, everybody. I mean, money can come from anywhere. I'm sure that they don't mind where it's coming from.
For sure. Simon?
Yeah, in answer to the question that was raised, I think it's probably the first time in medical innovation where we're really at this crossroad. For instance, let's talk about solid organ transplant. There was no company that could produce a liver for transplantation and participate into this. It was embedded in what we have been developing as a surgeon and as a medical innovation. It was the same thing for bone marrow transplant. There was no more sophisticated way of transforming the cells, etc. And it's hospital labs that have progressively developed techniques, and it entered the standard practice because there was no need or room for the biopharmaceutical companies to participate really in that. Now the North American model is based on a pharmaceutical model, and what has been put forward is, well, a T-cell product can be marketed just like another drug, and this model is known, and companies have embraced that, and they've made T-cell therapy available through investment in that, and they took risk into doing that. But it's not now there is this that works, but we have the entire freedom to say, well, there's an alternative way, and it takes one needs to be bold to do that. I think the Dutch government and scientists were bold 10 years ago when they decided to publicly fund a randomized control trial in T-cell therapy that would cost millions and millions of dollars to execute. But it's just a matter of promoting what we think is best to provide access to these new treatments in a sustainable way. There's no laws that can prevent us from doing that. I think it's speaking to awareness. Camille said, you need to be aware of what treatment options are available. But we're working, John and I and the BioCanRx team, to make everyone aware that there are many ways we can move forward to make T-cell therapy more available for Canadians.
So, John, what do you think about boldness? Is that part of the problem for Canada?
Yeah, I think we tend to buy into what's working in the States and think we should do that. And I don't think we should. I think we should do what's right for Canada. Right now, there was a question about whether or not we could do what the Dutch have done. And right now, BioCanRx is waiting to hear if we're going to get renewed. We've applied to the government. We're waiting for over a year to hear from them whether they're going to renew us or not. I sure hope they do. And if they do, top of our agenda is going to be to begin looking at a not-for-profit company model to support T-cell therapy, whether it be TIL or CAR T therapy. And I think that's the kind of vision that we need to have to make this happen. And the reality is it could definitely work, and we should do it because we like the fact that we have social medicine, and this is a great way to put that in action, be able to provide access to people across. I think one of the things Camille said, which is really resonates with me, is she advocated for herself. She made this happen. It shouldn't have to be that way. We should be able to provide access to everybody all over the country. And right now, we really just can't do that. But I think if we had a not-for-profit model where the money came back into the science, into the medicine, into the patients, that would actually make a lot more sense than providing dividends at the end of the year for investors. And I just think it's just a better approach for this particular kind of therapy. For Tylenol or, Viagra, that's a different story. Let the pharma companies take care of that. But I think for these kinds of life-saving therapies, we should use a new approach.
So specifically to the therapies that you each mentioned, there's a question about whether they might be delivered in Canada by a similar nonprofit model, to be as you mentioned, used in the Netherlands and in Spain.
Yeah, I think we definitely want to see that happen. I think it makes a lot of sense. And the fact that these two other countries have done it shows you that it's just a matter of will and vision at this point. So let's just go ahead and see if we can't make this happen.
And Simon?
Yeah, really, I think we should pursue this. I think we should not close the door for innovations that are coming from obviously the biopharmaceutical industry. We need to improve access in all ways possible. And in the specific context of a public health system, it makes a lot of sense to invest in our capacity to produce those cells and to redistribute profits towards access to care.
So, Camille, John says that patients will stand beside those who want to move in these bold directions. What do you think are some of the things that, and you also mentioned the role of patients. Could you talk about that a little bit more, how we really can be standing beside our researchers in this way?
I mean, the way I'm doing it is sharing my story. That's the best way I know how to help. I'm not going to lie. I'm still trying to recover from the last 3 years. I mean, I'm so grateful, but there's still a lot of work to do, I think, off topic, but with aftercare as well. But I mean, right now, all I need to do is stand by BioCanRx and continue to help advocate and share my story. And I know I've attended some BioCan on the Hill and trying to get the government to realize how important this is and how it saved my life. So I don't see why we can't save others.
Absolutely. So is there any, you talked about barriers earlier. I'm wondering if you have any other thoughts about policy barriers that might be You talked about dollar barriers. What about policy barriers? Are there any that you think are a challenge, John?
You know, getting a trial started is a lot of work, and there certainly are, you know, regulatory hurdles that we have to overcome. I think in general, there's an evolution. In my experience with Health Canada, for instance, who we have to go to, is that they are becoming more and more open to new therapies and trying to find ways to make these work. But it is, you know, a bit onerous. There are some things we have to do which don't really seem necessary, but are regulations that are ingrained within the government infrastructure that we have to do. They're minor points. I think the more important point really is the fact that Health Canada is beginning to see this as important for Canadians. They're open to changes, and I think they're also, you know, we often interact with the FDA, which the FDA is a good organization as well, but they're huge and they're hard to access. With Health Canada, you can go and speak to them, and you can have a dialogue to make things better. So I think there are hurdles, which sometimes the hurdles are important to overcome because they make you make sure you're doing the right thing. But I think it is getting better.
So there are a couple of questions also in the chat. Specifically, one is specifically about TIL therapy and whether there are predictive factors of treatment response identified.
There are factors associated with higher response rate that are inferred from cohorts of patients that have been treated. For instance, the more cells, the more TILs one receive, probably the higher the likelihood is of having a good response. But on an individual basis, there's no clear validated predictor, because some patients, for instance, have received a low number of cells, but yet enjoyed a complete response. So we don't yet have specific personalized tool to say you should or you should not try TIL therapy if you have a metastatic melanoma.
So what about the role of GPs and family doctors and oncologists? How are they being informed about the various trials? John, could you tell us about that?
Yeah, I actually, probably Simone's better to speak about it, but I think, you know, in areas in cities like Montreal and Toronto and Vancouver and Ottawa, where you have tertiary care centers like CHUM and at the Ottawa Hospital, you have a community of doctors who all talk and think about these problems. I think in the outer regions, it's probably harder for them to get this kind of information. So I'm not sure that there's a real good outreach to those doctors. And I don't know, Simone, are you more familiar with whether or not GPs and outlying agents get informed?
Yeah, no, what we see here in this situation may be different in Ontario and BC, is that specialized care does not necessarily interacts enough with general practitioners. Often forums or scientific symposium that are organized will not necessarily reach out to general practitioners organization when it comes from centers, academic centers. I think we need to continue to share progress and to make symposium that are specifically addressed to GPs, for instance, and so that they're informed of what's available, what's coming next, and can then be more up to referring appropriate patients for these types of therapy.
So speaking of availability, there's a question asking whether there are accessible, patient-friendly summaries of clinical trials that are available, and if not, the person asking the question would love to hear from you, Camille, on how understandable the trial information was for you and your family to assist decision making?
Louise, I mean, that's kind of difficult for me because by the time I got to this trial, I mean, I didn't really have any other option. So it was pretty easy to make that decision to go ahead with the trial at that point. As well, my family agreed with me that, I mean, my options were I was going to die or do the CAR T cell and possibly die. So I was going to take the possibly over the guaranteed to die. I mean, that's all I can say. I understanding it at that point. No, I didn't 100% understand exactly everything. I mean, they tried to explain it the best that they could, but until you've lived it, it's really hard to completely understand. There was a lot of things that happened that I didn't expect to happen, but again, it was successful. So, I mean, I got the result that I wanted to get. My advice to people is just ask as many questions as possible. Again, like I said, I had a family member that works at the Ottawa Hospital who's very knowledgeable and helped explain a lot to me. But I do know any questions I did have, the team was more than happy to answer any of them.
So, John, you mentioned Health Canada, and there's a question here asking if Health Canada and the provincial health authorities are supporting this work, even at the level of awareness raising.
Well, Health Canada is not really the people we speak to at Health Canada don't really supply money for this kind of research. This kind of research and development we get from other agencies, so like Canadian Cancer Society, Terry Fox, but also the Canadian Institute for Health Research, which is a federal government agency. We haven't had a ton of support from provincial governments so far for the program, except in British Columbia, where British Columbia has been very proactive and helped support us getting this trial going. So we're really appreciative of what they've done there. But in other provinces, not so much. And really, it seems to me this is something that could change because, as Simone said, I think quite eloquently, these trials are not just experiments now. These trials are becoming treatments. We knew when we treated Camille, there was a really good chance that she would probably have a great response and hopefully be cured of her disease. The old days, these trials were more, don't know what's going to happen. And I think with these new trials and the TIL therapy that Simone's spoken about, these should be considered to some extent almost standard of care for some patients, and they should be supported by our provincial agencies, because otherwise we're spending money on treatments which we know don't work. And I think that's really a waste of our funds. We should really be putting money into things that may work or have a good scientific basis for potentially.
Simone, would you like to speak to that?
Sorry, I was disconnected for when you asked the question, and so I just
that's all right. So it's the issue of whether provincial authorities are helping to raise awareness about the research that's being done.
I think it's to some extent, yes, but in different ways. Here in Quebec, there is a committee that responds to the Ministry of Health that has been created for cell therapy implementation, following how it is implemented and help monitor that and help advise on what's coming next. And this entity, the Comité National de Thérapie Cellulaire, also has a scientific program with presentations for physicians and for the public as well. And so in this way, the government participates into raising awareness.
So you feel you do get some support there.
Yeah.
Great. Well, I think we're going to have to wrap up the questions. Thank you so much to all of you for everything that you do, and we really are hopeful that some of the things that you've suggested will will come to fruition. So I turn it over to Stephanie for the last words.
Super. Thank you so much, Louise, for chairing this session. I too, on behalf of BioCanRx, I'd like to thank our co-chairs who helped organize this session, and of course our panelists for this incredibly insightful discussion. I know we're at time right now, but my final words, I once again very much like to thank Merck for sponsoring this public forum, and also to our panelists and to the folks that have written in the chat and the Q&A. There were some fantastic comments there. All I can say on behalf of BioCanRx, thank you. Camille, wonderful messages of thanks, incredible thanks for you sharing your story. Yes, so if you have a chance, Camille, please take a look. For those that have expressed support of BioCanRx, thank you. We will be in touch. And for those that are looking to continue this conversation with us about what's next, please don't hesitate to contact me or a member of my staff. But my email address is available on the BioCanRx website, and that is simply biocanrx.com. So on behalf of BioCanRx, thank you. As a final reminder, the session will be posted on our YouTube channel. And again, we love your feedback. We really listen to the feedback and adapt continuously. So a survey will pop up when you exit this webinar. And if you don't have moments, don't worry about it. We're also going to email it to you just to make sure that we get your comments. So thank you, everybody, for your fantastic questions and for spending an hour and a half with us hearing about this terrific research and plans for the future that we have for Canada. Thank you so much.